problem of asthma in children. What sort of a burden is there of asthma prevalent in the society now?
Yeah, so if you look at, there are two things that we need to realize here. One is wheezing disorders in children, and second is established asthma in children. Wheezing is very common. Okay, almost 50 to 60% of children.
These are two different entities, is it?
Totally,
or is it just a
totally. See, there is an old adage which says that all that wheezes is not asthma. Okay, so children below the age of 5 years will generally wheeze for many reasons. If there's a viral infection, they'll wheeze. Okay, if there's a little bit of pollution which they're exposed to, they'll wheeze. If they're exposed to, let us say, some organic volatile compounds, they will wheeze. So basically, that's not true asthma. Asthma is usually, what we do is we normally diagnose asthma preferably after 5 years of age. Though you can suspect it under 5 years of age and you can diagnose it also under 5 years of age, that generally we don't label anybody as asthma till they're around 5 and above. The reason is that there are large number of conditions which cause wheezing but are not truly asthmatic. Okay, they don't come with the recurrence that happens with asthma, with the same cough and wheeze and breathlessness and all things. So we try to differentiate between these two.
So that's the diagnostic criteria.
Yeah. So
repeated reproducibility of symptoms.
It is repeated and it is reversible with or without treatment.
That is asthma.
That is asthma.
Wheezing so is just a symptom which can be brought about by many.
Exactly, due to many things. Okay. So therefore, we need to distinguish between these two. But if you look at the true incidence of asthma in a place like Bangalore, it may be around 8 to 9%.
8 to 9%
of all children.
Of all children?
Yeah.
That's quite a significant
burden.
Quite a
significant burden, yes.
And usual age range they present to you?
We see children right from, starting from infancy till adolescence. So all of them, as I said, we usually diagnose asthma after 5 years of age because now there are more stringent criteria. Like for example, previously any child who came to me without fever and who had recurrent coughs and wheeze and things like that, I would diagnose on the basis of a clinical history and an examination and ruling out other things that may cause wheezing. But now what we do is we do a objective testing. Okay, we do a lung function test and show reversibility on treatment.
Okay.
When we show that, then we are more sure that it is asthma.
Okay. And what other criteria would they have to fulfill to get a diagnosis of asthma?
One, the most important thing is recurrent attacks. Point number 2 is many of them are without fever.
Okay.
Number 3, they are clearly airway obstruction. Number 4, that they are reversible. Okay, with or without treatment. Usually they respond pretty well to beta 2 agonist. That's the thing. Then in the background you could have atopy. You could have a family history. You could have skin allergies. You could have allergy in his nose, etc. So those are also things that will give you corroboration. But the fundamental thing is that the child must come to you with recurrent attacks of wheezing and breathlessness and cough. Okay, then you can take a call and say this is probably asthma.
So you diagnose asthma based on all these
criteria. There are clinical criteria, and the other thing which we also do is the lung function. If you show reversibility, okay, then we say yes, this is probably.
There's an improvement in lung function with.
Yeah. So basically, the child comes to you with a, let us say, with an X lung function, and then you give medication, and the lung function becomes, let us say, 1.5x. That means there is better. It is better by 50% or 30% or 20%. You say yes, there is reversible airway obstruction, fitting it with asthma.
So we got this diagnosis on a child now.
Yeah.
What sort of counseling do the parents get?
Yeah.
Now that you diagnose, it's a big thing, isn't it, for parents with a single child and you just diagnosed asthma?
Yeah. So basically, we tell them that don't start running behind other diagnosis. Don't label it something else. First step is accept that this is asthma. We tell them also the natural history of asthma, that most asthma is not going to disappear. Okay, it's not going to disappear with age, it's not going to disappear with whatever. Two things are important, one or two things are important. One is they accept the diagnosis. Second thing, they are ready for the treatment. Because many times the treatment is inhaled medication. And most parents have some limitation for giving inhaled medication because it may be addictive. Their fear is that it will become an addiction, that they cannot live without that.
Okay.
So these two things are to be addressed upfront. Then you talk to them about other things. The first most important thing is what is the possible allergen. So there are two kinds of things. One is an allergen which produces the allergic response in the body. The second is a precipitant or an irritant which can also do the same thing, but it does it only when you already have a wheeze. Okay. So there are two kinds of things. Now, for example, I'll give the one which is commonest in our country is what is called as the house dust mite. Okay, house dust mite sensitization will produce an inflammation in the airway and it produces spasm. So house dust mite is the first and thing. The second most common thing is cockroaches. Cockroaches are a major issue in our country. Third is molds, and this is something which parents don't often look at. Then fourth important that they need to look at also is whether there are pets in the house. Okay, then there could be pollen and other things which I am not going to go into. So these are 3 or 4 things that you need to keep in mind. Then you need to talk about what are the precipitants or the irritants that can do it. Cigarette smoke is one thing. Then burning incense is another thing. Third thing is this, some households can use this mosquito repellents which emit smoke. So to be careful about that. Then powders, they can be volatile organic compounds. They can be indoor air pollution. Many of the houses may use chula, that they burn firewood and then get that smoke into the house. So all these things can cause wheezing. So we need to tell them, caution them against the use of this. So the first step I tell them is look at these things in the environment. Control your indoor air environment. That's the first thing. Second is asthma is an inflammatory disease. So there are 2 steps in that. One is you have a normal airway. You have an inflammation. It becomes an inflamed airway. Then after that there is something which irritates it and you become a spastic airway. So you have to go from spasm back to inflammation and back to normalcy. So you have to give 2 kinds of medication. One kind of medication will reverse one part of it. The other kind of medication will reverse the other part of it. So these 2 things are very important to impress on the parent that you need 2 kinds of medication. The second thing is you need to impress on them that you need to give it through the inhaled route. That you have to give it only through the inhaler, not through an oral medication or tablet. The reason is that if you give it through the inhaled route, the dose is very much smaller, to the extent of almost about 100 smaller than if you give it orally. And if you give it there, it acts locally, doesn't produce much of side effects. So therefore, you need to learn how to give a local medication. So that's the next thing you need to impress on them. And third thing is how to give it. There are different ways in which you can give inhaled medication. You can give it through nebulizer, you can give it through meter dose inhaler, you can give it through dry powder inhaler. So the different ways you can do it. Best way to do it is a meter dose inhaler. We normally use a meter dose inhaler. We show them how to use it. And small children less than 4 years will need, all children will need a spacer, but small children will need with a mask. Older children will need with a mouthpiece. And how to use it. Most of the children will not know how to use this. So the next step is to impress on them what is the kind of medication they need to give, how to give it, and the method, rather the technique by which you would give it, like the spacer, etc. Then once you need to impress on them the dosages that you give. Explain to them that you are not giving high dosages that can cause side effects. You are giving them only mild to moderate doses. Most children will get away with moderate doses of wheezing medication. Tell them that. Then the next thing is they need to follow up very, very clearly, because this is a repetitive disease. So you need to know what is the meaning of control. You need to explain to them what is control in asthma. Control means no having nighttime cough, no getting wheezing while running around, no missing school. So all these things you need to tell them that if any of this happens, please come back. Dose is not sufficient. We need to readjust the dose. So you explain to them that. Then after that you tell them also there is no limitation. Once he is all right, he can do everything. He can eat everything. He can go and play wherever he likes. In fact, you give him the example of people, sportsmen who were asthmatic and who played test matches. Okay, tell them Ian Botham and others played, test matches even after being asthmatic. So issue is you need to tell them that there is no limitation on this. Then the next step you need to tell them is proper lifestyle. Because what happens is many of these children, because of this wheezing, the mothers don't send them outside to play. So their physical activity is restricted. Then they are restricted with food, so they tend to start eating things which are not right. They start putting on weight. Then you tell them also the importance of regular sleep, because many children may not sleep very well. So tell them that you need to see that the children get to bed. Don't allow them screen times, etc. At least 2 hours before they go to bed. And if older children can see maybe 1 hour, not more than that in a day. Smaller children less than 5 years and 6 years, nothing, no screen at all. So all these things you need to explain to them. Educate them. Then the value of regular exercise. Tell them exercise is very important. Okay, food is important, their sleep is important, their exercise is important, their vitamins are important. Because vitamin D is a very important thing. In our country, 80 to 90% of children are deficient in vitamin D.
You would think in India being such a sunny country.
Yeah, so it's a challenge. But vitamin D supplementation is important. Regular deworming is important. So all these things you need to talk to them beforehand. Lifestyle changes, irritant avoidance, allergen avoidance, proper use of medication. And the important thing, very important thing is how to monitor objectively. So give them a peak flow meter. Tell them monitor your peak flow. It takes not even a minute. Monitor it once, at least twice. In more serious cases, monitor lung function. Do it at least once a year.
They can do it.
They can come to the hospital. Come to the caregiver and do a lung function. Just don't take some medicine and go away. Do a lung function. It's important because we'll know what is the degree of control. Okay, now with the newer machines and all, it's very easy. So they should come and do it, and it doesn't cost too much also. So I think there are lot of things we can do, and then you give them a written action plan. You tell them this is what you need to do, and also how to recognize an emergency and what to do in an emergency. Now, supposing they are on a picnic or they are gone somewhere outside, suddenly the child starts wheezing. Tell them, take your spacer, take your inhaler with you. Give it. Okay, give even up to 8 puffs. You can give, no problem at all. Nothing will happen. The more you give, the better. So rescue medication is important. Tell them where they need to reach out. In case they have a problem, they need to reach out to the nearest hospital. Give them the address. Give them a pulse oximeter. Tell them how to use a pulse oximeter. Look at the saturation. If it goes below 90, then be careful. So all these things you need to teach them at one time. But again, important thing is don't try to give them everything under one shot. They won't remember anything. You give them in small bits. Okay, so this is what we do normally.
So it's a process, isn't it? It's not a one-time
absolutely,
thing.
Absolutely. Many countries have got what are called as asthma nurses who do all this. I know for England, Britain does it. Okay, we don't have the facility for that, so everything is done by us only.
You have to do it. Yeah. How often do you have a specific precipitant?
Yeah, we do now. See the advance which has taken place in the last few years. We now know that there is a small segment of asthmatics who are allergen sensitized, who can be desensitized.
Okay.
So we need to find that out. We need to take a good history. Usually these children will have an allergic rhinitis with an asthma. So because they inhale the same allergen. Okay. So testing them is important. You can get them, if there is a problem, and sort it out.
So once you find a specific allergen or a precipitant, you are able to modify the disease. Are you able to cure it?
Well, that's a very good question. At least we can reduce and bring down the inhalers quite significantly. As I said, curing is not because asthma is not a disease. Asthma is a reaction of your body to an allergen. Correct?
So they're stuck with it for the rest of their life?
Well, that's a good question. I don't know about that. I can't tell you whether they are or not. But whatever studies have come out till now, we know that many asthmatics can go in for chronic obstructive pulmonary disease in later adulthood. So it's possible.
Any advancements that is taken?
Plenty. I think there is what is called as the GINA guidelines, which comes out every year. The major advance which has come out right now is the use of steroids every time you give a beta-2 agonist. That means you give, as I said, the 2 steps are there. You don't treat each step separately. You treat both of them together because they are part of the same disease. So you give a combination of a drug called as formoterol with a steroid, that is budesonide. So we give both together, then what happens is that you control both the arms of both the inflammation and the spastic area. That is the one major advance. The second major advance is the use of biologics. A lot of biologics which have come out now, which are useful for severe cases. Okay, and seasonal, severe, defined conditions, we can use them. But they are expensive, and in our country, fortunately, we don't have many children who have got such severe asthma. So vast majority can get away with just simple treatment in the clinic or in an outpatient department. We don't really even have too many admissions for asthma. So ours is a different phenotype altogether. So we are fine. We are okay with it.
Nice. What about this immunotherapy?
Yeah, that's what I'm saying. So immunotherapy is good when you have an older child. Okay, because you can't do it for very young children. When you identify a specific allergen then you can subject them to either sublingual or the intradermal immunotherapy. But for that, what we do is at least I refer it to an allergy specialist. I don't venture into that because that's not my field. Okay, my job is to identify which are the patients in whom allergen testing and immunotherapy is going to make a difference. That's what I have to do. Rest of it will be handled by the allergy specialist.
That's nice. That's nice. And do you think this is an urban problem, or is there
absolutely
similar incidence in rural as well?
No. Rural is much lower.
Lower.
Much lower. And the reasons are many. First and foremost is the amount of air pollution. Okay, the rural area there's not much of pollution as of now. Second thing is that the indoor part of it is, I mean, yes, there are chulas and other things, but this excessive house dust mite and other things are uncommon in a rural area because of the ventilation that is naturally there. It's not a cooped up kind of place, And again, hygiene, cockroaches, all those things, molds, these are a little uncommon in other areas. So exposures are less, nutritional challenges are less. So many things happen there.
So there is a difference.
Yes. And of course the old theory of Th2 and Th1 inflammation. Okay, so that again is it's skewed more towards the infection rather the allergic pathway. So that again is different in the rural area.
Very nice. So to summarize, it is common in the urban region.
Yeah, it is common.
Education awareness is important.
Yes.
And if they seek early advice and intervention, it's not all doom and gloom. It can still be kept under control.
Yeah, I think the most important thing to realize is that every child with asthma is different. There are no standard rules for anybody. Guiding principles are there. You have to, as a clinician, sit and understand from the family what is going on and from the child. If I saw a child who's not gaining weight and who's having cough and wheeze going on for some time, I would look either at an alternative diagnosis or at a very severe asthma which has not been treated or what we call as an uncontrolled asthma. So look at that.
Wonderful. So what happens if you don't seek treatment at all? Natural
lung function gets damaged significantly. And many of these children will have significant problems when they grow up. Okay, like for example, exercise intolerance, inability to, let's say you want to run a half marathon, you can't do it. So those things are challenges.
Yeah. Probably scholastic performance would come down.
Scholastic may or may not, that's the difference, because many of these children will do well in school but not do well in sports.
Sports is a problem.